So, hi friends, today we are going to discuss about arrhythmias. Basically, we are dividing the arrhythmias into two: tachycardia and bradycardia. By simply looking at the heart rate, tachycardia is heart rate more than 100 beats per minute. Bradycardia is heart rate less than 60 beats per minute. So initially we are discussing about tachycardia, then we will move to bradycardia. So first topic is tachycardia. Tachycardia can be further divided into narrow complex and wide complex. So first we have to look QRS complex. QRS complex. Narrow or wide. So this is our narrow QRS complex. Narrow QRS complex is defined as QRS complex duration less than 120 milliseconds. For wide QRS complex, it is more than 120 millisecond QRS. Okay. Narrow again further divided into regular and irregular. Wide also regular and irregular. We have already discussed what is regular. Regular is nothing but the RR interval is same throughout the ECG, and if it is RR interval is irregular, it's called irregular. So the examples of narrow regular tachycardia are sinus tachycardia, sinus tachy, atrial flutter, and supraventricular tachycardia SVT are the examples of narrow regular tachycardia. For narrow irregular tachycardia, the examples are atrial fibrillation and multifocal atrial tachycardia. For wide regular, the examples are monomorphic Vt and SVT with aberrancy. These are the two DDs of regular wide tachycardia. It is monomorphic Vt and SVT with aberrancy. And the irregular wide tachycardia is polymorphic Vt. Okay, so we are going to discuss one by one. So our first topic is sinus tachycardia. Okay, as discussed above, it is a narrow regular and heart rate will be more than 100 beats per second. So the causes for sinus tachycardia can be physiological or pathological. The physiological causes include pregnancy. In pregnancy, there will be elevation of heart rate around 15 beats per minute, and other one is exercise. In exercise also, there will be tachycardia. Pathological causes include anemia, heart failure, thyrotoxicosis, hypovolemia, and in pulmonary embolism also there will be sinus tachycardia. That's about sinus tachy. Moving on to supraventricular tachycardia, SVT. So the ECG features of SVT, as already said, it is a narrow regular tachycardia, and first feature is absence of normal P wave. There is no sinus P wave in SVT. This this ECG strip, there is no definite P wave. Okay, and narrow regular QRS complex. And the ventricular rate in SVT is usually ventricular rate, or the heart rate in SVT is usually 170 to 180 beats per minute. So the first treatment for a stable patient coming with a SVT, the first line of management is nothing but it is vagal maneuver. Okay, it is vagal maneuver, and the drug of choice, or the second line of management, or the drug of choice for SVT, stable SVT, is IV adenosine. IV adenosine. Okay, the first line is vagal maneuver, applying pressure over the carotid at the level of thyroid cartilage, and the drug of choice is, if not subsided with the vagal maneuver, the drug of choice is IV adenosine. Okay, so moving on to next narrow regular tachycardia is atrial flutter. So the ECG features of atrial flutter is, there will be identifiable P wave. Identifiable P wave. And the P wave is of single morphology. Not more than one type of P wave. The all P waves will be single morphology. Again, the atrial rate, that is the rate of P wave. Atrial rate is regular, and the rate is around 300 beats per minute. But the ventricular rate, that is the rate of QRS complex, ventricular rate is also regular, but 150 beats per minute. It is due to 2:1 AV nodal block. That is why the atrial rate 300 is not conducting to ventricle. Only half of them is getting conducted. So the ventricular rate is only 150 beats per minute. So that's all about the narrow regular tachycardia. Moving on to narrow irregular tachycardia, we have atrial fibrillation. Atrial fibrillation. So the ECG features of atrial fibrillation include, first one, absence of identifiable P wave. There is no definite P wave in atrial fibrillation, and there is irregular ventricular rhythm. Irregularly, the term used is irregularly irregular ventricular rhythm. That is the ECG feature of atrial fibrillation. So the atrial rate will be atrial discharge rate will be around 450 to 600 beats per minute. But all atrial firings are not conducted to ventricle due to AV nodal delay, and the AV node responds only intermittently. That is why the ventricular rhythm is irregular. Okay, and the main risk associated with atrial fibrillation is nothing but embolic stroke. So the risk for embolic stroke is assessed by score called Chad's-Wasc score. And the maximum score is 9. I'm not going to the details of this scoring. It will be discussed in separate topic. So the treatment for a stable patient coming with atrial fibrillation is either beta blocker or calcium channel blocker or digoxin. But if the patient is coming with unstable features, the unstable features like hypotension, shock, altered mental status, ischemic chest pain, then we have to, for unstable patient, the treatment is synchronized cardioversion. Previously, the joules for the cardioversion for atrial fibrillation patient is 120 to 200 joules. Okay, that's all about atrial fibrillation. Moving on to next narrow irregular tachycardia is multifocal atrial tachycardia or MAT. Multifocal atrial tachycardia. To diagnose MAT, at least three distinct P-wave morphologies should be there in a single ECG lead. Okay, again narrow, complex, irregular. This is also irregularly irregular. Rhythm should be there in ECG, and at a rate, normally the MAT is at a rate of 100 to 180 beats per minute. That's about multifocal atrial tachycardia. So we have finished with the narrow complex tachycardias. Moving on to the broad complex tachycardia. In broad complex tachycardia, first we have monomorphic Vt. So in monomorphic Vt, the ECG features are no P wave. This is the ECG of monomorphic Vt. You can see here there is no P wave, but the ventricular rhythm is regular wide complex. Usually the heart rate is around 140 to 180 beats per minute. Okay, but I already mentioned the commonest DD of a monomorphic Vt is Svt with aberrancy. So there are certain features which can used to identify Vt, monomorphic Vt, from the Svt with aberrancy. So the features are positive QRS concordance in the chest leads. Okay, all leads will be positive. The QRS complex will be positive in all chest leads. So the ECG findings exclusive for Vt, monomorphic Vt, is to differentiate from SVT with aberrancy is, first one is positive concordance, positive QRS concordance in chest leads. Second one is marked left axis deviation. The third one is you can get fusion beats and capture beats. Fusion beats are nothing but normal beat fused with Vt. Here it is a normal beat fused with Vt. Here, that is our fusion beat. The capture beat, this is the capture beat, that is a normal QRS between abnormal beats. This is a normal QRS between the abnormal beat. That's our capture beat. So that's how we are differentiate monomorphic Vt from SVT with aberrancy. So moving on to the broad irregular tachycardia. So first one, polymorphic Vt. This is not pulseless Vt, it's polymorphic Vt. So no P wave associated with QRS complex. Again, rapid and irregular rhythm. Heart rate will be around 140 to 180 beats per minute. QRS complex will be wide, that is more than 120 milliseconds. There is one variety of polymorphic Vt that is called Torsades de Pointes. You can see in this ECG, it's a polymorphic Vt that changes in amplitude and cycle length, giving appearance of oscillation around baseline. Okay, it is a type of polymorphic Vt that changes in amplitude and cycle length, giving appearance of oscillation around baseline. The polymorphic Vt, in simple words, the Torsades de Pointes can be defined as polymorphic Vt with long QT interval. So the causes for Torsades de Pointes are any condition that increase QT interval, like hypokalemia, hypomagnesemia, drugs like quinidine, tricyclic antidepressants, etc. So the treatment for Torsades de Pointes is magnesium sulfate. Okay. So the last type of tachycardia is ventricular fibrillation. Ventricular fibrillation patient usually present in cardiac arrest state because of the impaired pumping of the left ventricle, and the treatment is nothing but defibrillation. There's a giving shock at 200 joules in a biphasic defibrillator. Okay, shocking at maximum available joules. So that's about the tachycardias. Moving on to next topic, our bradycardias. Bradycardia. Again, the causes of bradycardia are we have Sinus Bradycardia, or it is due to P wave or the stimulus coming from any other area other than our SA node, that is like junctional rhythm, or if the stimulus is coming from ventricle, it is called Ideo ventricular rhythm, or it can be in heart blocks like first degree heart block, second degree heart block, and third degree or complete heart block. Let's see one by one. So first about sinus bradycardia. Heart rate will be less than 60 beats per minute. Again, it is also seen in physiological conditions and in pathological condition. So the physiological conditions associated with the sinus bradycardia are seen in athletes, elderly patients, or during sleep. There will be physiological bradycardia. And the pathological causes for bradycardia include vasovagal attack, acute MI, in acute MI, especially inferior wall MI, sick sinus syndrome, and drugs like beta blockers, hypothermia. In hypothermia, there will be bradycardia, and also in raised ICP as a part of Cushing reflex, there will be bradycardia. So the treatment for bradycardia is, in stable patient, we have to observe them, but for unstable patient, the treatment is, drug of choice is, first drug is atropine. If it is not subsided with atropine, we have another drugs like epinephrine and dopamine. If it is not subsided with the dopamine and epinephrine, we can go for pacing. Okay, that's about sinus brady. Now we are going to next cause of bradycardia, that's our junctional rhythm. So in junctional rhythm, in the previous videos, we have already discussed the wave is, the stimulus is from AV node. So there will be no P wave, or if the P wave is present, it will be inverted due to the retrograde conduction. So absence of normal P wave, or presence of inverted P wave will be there in junctional rhythm. Again, QRS complex will be narrow. As it is supraventricular in origin, the QRS complex will be narrow. So the usual ventricular rate is between 40 to 60. But in case of an accelerated junctional rhythm, it will be around 60 to 100. If it is junctional tachycardia, the heart rate will be more than 100. So in this ECG, there is inverted P waves due to retrograde conduction, and in this ECG there is no P wave. Okay, that's about the junctional rhythm. Now about the idioventricular rhythm, that is, a beat is originating from ventricle. So as it's a ventricular rhythm, there will be wide QRS will be wide and no P wave. It is originating from ventricle, so there won't be any P wave, and the ventricular rate is usually 30 to 50 beats per minute. And in accelerated idioventricular rhythm, the heart rate will be like 50 to 110 beats per minute. Okay, so wide QRS, no P wave, and the QRS will be regular also, regular, because the ventricle is beating at its own rhythm. The QRS will be regular. Okay, and the usual normal heart rate is 30 to 50 associated with the ventricle. If it is increased to more than 50 to 110, it is called accelerated idioventricular rhythm. Now moving on to the heart blocks. So first degree heart block. So the first degree heart block, there will be a P wave followed by QRS complex. So there will be consistent P wave to QRS complex relationship. So there will be consistent P wave to QRS complex relation. Every P wave is followed by QRS complex. But the problem is PR interval will be prolonged. PR interval will be more than 200 milliseconds. You can see this is a prolonged PR interval, but it is fixed. It is same in all waves. Okay, it is fixed. That is first degree heart block. Moving on to our second degree heart block. Second degree heart block. It is further divided into Mobitz type 1 and Mobitz type 2. So first about Mobitz type 1. As you can see in the ECG, there will be progressive prolongation of the PR interval. Here the PR interval is small. It is prolonged, followed by a non-conducted P wave. This P wave is not conducting. Okay, that is the definition of Mobitz type 1. Progressive prolongation of PR interval followed by a non-conducted P wave. Okay, after this non-conducted P wave, the cycle repeats. After non-conducted P wave, cycle repeats. Okay, this is what has happened in Mobitz type 1. Moving on to Mobitz type 2. In Mobitz type 2, the PR interval is remain constant. You can see the PR interval is same. Okay, PR interval is constant. So what happens is there will be intermittent non-conducted P waves. Intermittent non-conducted P wave. Here this P wave is not getting conducted. Okay, and the QRS complex is usually widened. Usually, not always, usually QRS will be widened. Okay, that's Mobitz type 2. So moving on to complete heart block, third degree or complete heart block. So in the third degree or complete heart block, there is no association between P wave and QRS complex. Okay, so the atrium has its own rhythm and the ventricle has got its own rhythm. There is no relationship between atrium and ventricle. So the atrial rate will be more than ventricular rate, as atrium can generate at a faster rate. The atrial rate will be more than ventricular rate. And again, the ventricle has got its own rhythm, because the ventricular rhythm is originating from the ventricle. The QRS complex will be wide. So there will be wide QRS complex as the beat is originating from ventricle, and the ventricular rhythm will be regular. The RR interval will be same. You can see it is same throughout the ECG. So ventricular rate is regular. That's all about the tachy and brady arrhythmias. Okay, thank you.